Thank you, the first pioneer, Yosef. Thank you very much for turning on that video. Whoever else does gets 10 extra points. Okay, good evening, everybody. Welcome to another episode of Mondays with Maishi. This is Moshe Norman out of Lakewood, New Jersey. It is today, March 24th, 2025. I know I'm getting older because it's harder for me to see the screen and the numbers on the screen. But I'm still not as old as, I still don't look as old as I am. So that's always good, I guess.
That is good.
Or is it? Right? Okay, so it's just after 9 p.m. and we have a nice crowd joining. And welcome back, everybody. It's really nice to have you back and to see you. And tonight we are honored to have Dr. Brian Marx from Boston University. So that's out in Boston. I think we've had a number of people recently from the Boston area. So it's really nice to have you on to talk about some of our members' favorite topic, which is the topic of trauma. But this time, trauma treatment with a bit of a different twist. So first of all, Brian, thank you very much for agreeing to do this and coming on tonight.
Thank you very much for having me. It's a pleasure to be here.
Okay. Brian, just give us a little background. Tell us who you are, what your relationship with trauma is, how you got into it, um, where are you serving now, what faculties, what centers are you serving on, and how you sort of came face to face with written exposure therapy, which is our topic tonight, and then we'll talk about what specifically it is. But just give us some background.
Absolutely happy to. Um, I am currently the Deputy Director of the Behavioral Science Division of the National Center for PTSD at VA Boston in the Department of Veterans Affairs. The National Center for PTSD is a multi-site consortium that is here in Boston. It's at the West Haven, Connecticut VA. It's at the White River Junction, Vermont VA, Palo Alto, California VA. And the mission of the National Center for PTSD is to conduct research on PTSD to help inform treatments and improve the care of veterans and others who have been experiencing trauma. And also to help educate both the public and patients with PTSD about the disorder so that we can reduce stigma and improve the care and the well-being of those with trauma-related disorders. In addition to that, as you said, I'm a professor in the Department of Psychiatry at the Boston University School of Medicine. I have a faculty appointment there, and I do some work for them as well. The other thing that I do is I do work on the suicide prevention side, and so I'm also the co-director of the VA's Suicide Prevention Research Impact Network. And the aim of it's called Sprint. The aim of Sprint is to try and provide resources and education and training for the purposes of reducing suicide among veterans, but also others, service members and others who are at risk for suicide. So I feel fortunate to be able to, work in both of these domains. I feel like it's a calling for me, both of these things. It's important work in my view. There are a lot of people who have suffered from trauma and there are wars going on in the world that I'm sure everyone here is well aware of. And so there's no shortage of the need for people to help those who have been traumatized. So that's really kind of where I'm at, what I'm doing, why this all matters to me.
Mhm.
As far as how I got here. It all started for me back in 1989. I was just I graduated from Boston University and ended up becoming a research assistant at the National Center for PTSD, right at the time when the National Center for PTSD just started. And so I was there for 2 years. It was there that I learned about post-traumatic stress disorder and really kind of fell in love with the idea of studying it. and wanting to be part of that community that did work in that area. So I went up to graduate school. I'm born and raised in the New York City area, went to college in Boston. So I was, in the Northeast for my childhood and decided that I would go to graduate school someplace else. I ended up in Mississippi. Thought that would be kind of an adventure for me, and it most certainly was. And so I got to see and do and experience lots of pretty interesting things in graduate school. Ended up at a faculty position in Oklahoma and then traveled to Philadelphia, where I was on the faculty at Temple University, and then found my way back here to Boston in 2006.
Hmm.
Came back to the National Center for PTSD as a staff psychologist, and now I'm the deputy director of the center.
Cool.
So,
That's
yeah.
a full circle
It
almost.
is, it is indeed. It is indeed. And I'm really excited to be back here. It's really, I sort of feel like my professional home, and it's felt that way for a very long time. So I'm really pleased to be back here. As far as written exposure therapy is concerned,
How did that happen?
that work started um, around, well, I would say in the mid 90s. When I was at my first faculty position at Oklahoma State University, I became aware of some work that was done by a social psychologist who was studying the expression of emotion. And this psychologist was named James Pennebaker. Pennebaker did a series of experiments in which he showed that this very brief writing technique in which people were instructed to write about a stressful or traumatic experiences with as much emotion and sort of sharing their thoughts, their private thoughts about that experience as much as they possibly could repeatedly over the course of several times, showed that that resulted in really significant changes in both people's mental and physical well-being. It was this very straight ahead, very brief writing procedure. And, when I first learned about it, I was very skeptical because it seemed very silly, very easy. Um, and, but the science was very clear. Study after study showed this repeated effect that if you expressed your feelings through writing about these things that happened to people that they never shared with anybody else, that it resulted in very profound benefits, both physically and emotionally. What I noticed at that time was it looked very similar to some of the things that we do from a cognitive behavioral perspective with trauma survivors with PTSD, in which we do something called exposure therapy. It looked very similar, except it was only five, or it was even 3 sessions of writing in Pennebaker's original protocol. So it was very short, very brief, but it looked very similar in terms of what people were being asked to do. I didn't do anything about it until I met Denise Sloan at Temple University, and she and I decided that we would do some work together to study this. And we set out to do a series of studies, the first of which was published in 2001. And we we really kind of put Pennebaker's protocol to the test. And to his credit, I will say that Jamie Pennebaker was really very nice and generous to us. We contacted him, we asked him for all of his materials, we asked him for the instructions, and he said, sure, here it all is. Have fun. And we did some work that I would say we were very skeptical of at first. We didn't believe that we would see this, especially with folks who had really bona fide traumatic experiences, such, being exposed to assaults and rapes and child abuse and all kinds of terrible things that Pennebaker, in his original experiments didn't really codify very well. But here we were really interested in people who had experienced truly horrific, life-threatening experiences. Uh, and much to our chagrin, we actually found that it still continued to work. And so we were intrigued by that and continued to then do study after study to see what sort of the limits were and how we could test what the different, how we could improve the writing, um, where things might fall short, and so on and so forth. And ultimately, it led us to where we're at today, which is the development of a proper therapy protocol known as written exposure therapy.
And so who is the founder? Who's the formal founder? Is that you and Denise or
That is,
okay,
yes.
amazing. Okay, so just before we jump ahead of ourselves and we talk about written exposure, I'm just curious because you're talking about the research that's done um, in the VA, and I've heard so many different, I guess, approved trauma treatments or PTSD treatments at the VA that have been studied and approved. Are you familiar with some of the other um, trauma treatments that have been incorporated into the VA? Can you share, what some of them are?
Yeah, the two big ones are cognitive processing therapy and prolonged exposure. Prolonged exposure was developed by Edna Foa. Um, Patty Rezick, what is the developer of cognitive processing therapy. Both of those treatments are considered to be the standard of care for post-traumatic stress disorder, along with EMDR, I should say. But in the VA, there are fewer people who use EMDR than they use PE and CPT.
Oh,
Um, and so the VA has spent a lot of time and a lot of money and a lot of effort to roll out prolonged exposure and cognitive processing therapy across the VA system. So there are thousands of psychologists in the VA who are trained in PE and CPT, and it's assumed that they will regularly use one of those two treatments with veterans who are suffering from PTSD.
hmm,
More recently, now WET is one of the other treatments that is now offered in VA.
interesting. Well, that's written exposure therapy that we're going to discuss tonight.
Yes.
Interesting. Aaron Herzog is on tonight. Aaron, first of all, thank you, Aaron, for connecting us, Brian and myself. Uh, I can't recall, but some months ago, maybe close to a year ago, I had somebody on who was discussing one of the trauma treatments, one of the founders of one of the trauma treatments, and also said that their trauma treatment was incorporated as one of the approved VA treatments. Aaron, do you remember who that was and which treatment it was? I'm gonna have to go back and remind myself, but there was somebody else who was claiming the fame to that. So just wondering if I could remember who it was and what modality I would ask you about it. Okay. So if anybody remembers, please shout it out. Okay, so let's talk a little bit about about written exposure. Obviously from the way it sounds and from what you've described, I'm hearing that there's a protocol of writing, and I'm going to guess that the writing, one of the advantages of the writing is that the client or the patient doesn't have to talk and become highly activated through talking.
You
That's at
got that
times
right.
okay. And so then the process goes through writing. And so what is it that, are we as the therapist, in doing written exposure, are we looking for clues in the writing? Are we looking for explicitness in the writing? Are we looking for projection in the writing? What is it specifically that we want to have the patient do?
That's an excellent question. And the instructions that we have for the writing are different than what Pennebaker originally had, which was, again, it wasn't meant to have the person confront something as severe as a rape or a child abuse situation or a car accident, but just, to kind of very vaguely write about something that was stressful or quote unquote traumatic for them. Um, Over time and through the means of, doing a lot of different studies, we modified his writing protocol such that we changed it first of all to increase the number of sessions that people would write for. So again, in Pennebaker's original protocol, he only had 3 sessions, and people would either write for 15 or 20 minutes at a time. Through our work, we kind of found out that for people with, you know, a diagnosis of PTSD, that was simply just not sufficient. And so, first of all, one of the things that we did was we beefed up the number of sessions and the amount of time that people would write for.
5 sessions, right?
5 sessions, 30 minutes of writing each session.
Okay.
We included in the first session, we include now some psychoeducation material about PTSD and how to treat it, as well as the treatment rationale for written exposure therapy, why we think that this is helpful, just to give some people some understanding about why they're doing what we're asking them to do. We feel like that's very important. And all treatments, generally speaking, have that as part of the initial work, is to explain, here's why we're here, here's what we're doing, here's why this is important. So that goes into session one. And then in each of the 5 sessions, there's 30 minutes of writing. The first 3 sessions are really meant for the individual to provide in as much detail as they possibly can their traumatic experience, much in the same way as if someone was doing a session of exposure therapy and they were being asked to recount to a therapist what happened to them.
So they're actually recounting the story in its detail on paper.
That is correct. They would be doing that in the first 3 sessions. Um, and And so usually that's very challenging for people, as you might imagine. You're thinking about it being less difficult because it's being done through writing is exactly correct. We find that it is much more tolerable to ask somebody to sit and do it, and not have to verbally disclose this to somebody, that instead they put it on paper, then the therapist after the session reads it. And so, the next time that the person comes in, the therapist has an awareness of what the person has written about, but they don't, he does, the patient doesn't have to explain it to them. It's already there. Um, so that's done in the first 3 sessions. I will say that each session starts with reading of very specific instructions to the client. Um, the instructions are very scripted. That is intentional to make sure that uh, the the treatment is standardized. So it doesn't matter if you were seeing a patient or I was seeing a patient, that they receive the same set of writing instructions in the same way, regardless of who is seeing them. So then the person would write for 30 minutes. At the end of that 30 minutes, there is a brief check-in. Um, that brief check-in is meant to do a couple things. Number one, it's meant to kind of calm the person down before they leave the therapy session, but it's also meant as a means to kind of do some meta processing about the writing. We're not interested in having that person once again start to recount details of their
Right.
trauma. Instead, it's really more about asking the person to talk about what the process of writing about their trauma was like. Did they
Mhm.
remember certain details that they thought that they didn't remember? Was it harder than they thought it would be? Was it easier? What was that experience like?
And
Um,
are you using that information for anything other than just having them process it?
It depends on the patient per se, but we're really more interested just to kind of get a sense of what their experience was like, and to check in and to make sure, if nothing else, it's to kind of help us understand whether or not they actually participated in it the way we would hope that they would. Of course, after they leave the session, we'll read their narrative. So, and that's the real check to kind of make sure that they actually did what we're asking them to do. The next time they come in, if they didn't quite follow instructions or if they need additional guidance, or we'll give them feedback to basically say, the last time you were in, here's what you wrote about. You did a great job providing details about this part. I'd like to see more details about this other piece that you seem to gloss over in your narrative. So when you write again about it, please try to focus in on this and give as much detail as you possibly can in terms of what you saw, what you heard, other kinds of sensory experiences, things of that nature.
I just want to invite everybody, if you have any questions or comments, please raise your hand. I noticed that on some of the past recent shows, people raise their hands all the way at the end when there was no more time. So
By all means.
if you're gonna jump in, please do it before it's too late, and then I have to feel bad and you have to hate me.
Ye-
So Brian, quick question. You talked a little bit about some of the psychoeducation that you share with clients, such as why is it helpful to write? What do you share with them? How do you explain to the patients or the clients why it is in fact helpful to write out their trauma story?
Well, the first thing is what we do is we explain to people what PTSD is, what are the symptoms. We spent a lot of time talking with them about avoidance, which is really, one of the hallmark symptoms of PTSD, and it is perhaps the symptom that ends up impacting people's lives in very profound ways. It kind of keeps them boxed in. It prevents them from doing things that they enjoy, being with friends and family and engaging in activities and so on and so forth. And so we first start off with talking about what PTSD is, how it develops, the symptoms, um, and kind of going through a whole sort of discussion about what the symptoms might be that are, relevant for that person. Following that, we'll then talk about the rationale for doing the writing. And again, it's really about confronting the details of the trauma memory in a organized, methodical fashion. Um, the thinking there is, first of all, to overcome the tendency to avoid, which we know, is a very strong impulse for people with anxiety disorders and PTSD. So first, getting over that impulse to avoid, um, and then trying to work through the memory, because we know that traumatic memories oftentimes are disorganized. They can be stored in a bit of a splintered fashion. And so, for the purposes of working through and healing, um, it's helpful to try to reconstruct the trauma memory in a way that can be beneficial. And so, doing that through writing can work for a lot of people. And so we explain that to them. And then I will say, in contrast to, let's say, prolonged exposure, which, the first couple of sessions in PE are kind of meant to set the stage for actually doing the imaginal exposures. And then what happens is the person is sent home and they're told the next time you come back, we're going to actually start this whole, recounting of the trauma memory. We're going to do multiple sessions in which we're going to go through this. And what happens is a lot of times for people is they get scared, understandably so. And that many patients, that's the point at which they drop out
Drop
of
out.
therapy because they say, I spend every waking hour trying not to think about the trauma memory. And here, this person is telling me that this is exactly what we're going to do. And no, thank you. So they leave. In written exposure therapy, that doesn't happen because we dive right into the writing in session one.
Hmm.
We don't give people an opportunity to say, I'm not coming back. We do it right at the very beginning. Um, and I would say much of the time, if not most of the time, after it's done, people realize that it was not as bad as they thought it was going to be. And so I would say a consequence of that is that written exposure therapy has much less dropout than other trauma-focused treatments that focus on, recounting the trauma memory because you're already kind of in it at the end of session one. You've already done it once. Um,
And is it less, I'm assuming it's also less triggering than talking, so it's they discover that it's really tolerable.
That is exactly correct. And
Mhm.
we also, I will say, one of the features of the instructions that we give people, and this is intentional, is to write about it as if as they're looking back upon it right now. So, in contrast to prolonged exposure, in which people are told, we want you to recount the trauma memory as if it is happening right now. We want you to do it in first person, present tense, as if it's happening all over again, which, can be very distressing for people and intolerable. And understandably, why people would want to avoid and not come back to therapy if they're being told to pretend as if this is happening all over again. Instead, what we do is we take a bit of a different approach where we ask them to um, write about it as if they're looking back upon the experience right now. So almost as if, let's say, you are um, a reporter that was sort of on the scene of a crime, a car accident, but you're not that person that was actually
So
in.
not to actually relive it and become
Correct.
re-traumatized, but to watch it as an observer.
That is correct.
Okay? And here's a picture of the book, Written
Oh, look
Exposure
at that.
Therapy for PTSD, for those of you.
It's got the price on it and everything.
And it's $3.99 for shipping, by the way. But not if you get it from Amazon or,
Right.
but here, this is it. Okay.
Yep, that's right. That's the second edition just came out a couple of months ago. We're really happy with that. The new manual that we just published has new chapters about doing it over Zoom and things that which like when we wrote the book the first time around, we didn't even think about, using written exposure therapy over a Zoom platform or anything like that. It was
Interesting.
like the
Can you like
furthest.
do it in the chat box, the whole written exposure?
Say that again.
Can you do the whole therapy in the chat box, like typing it up?
No, the person will actually do the writing. That's a really good question, and one of the things that we are curious about that we haven't had an opportunity to study yet, whether or not it's just as effective if the person types it versus they
Mhm.
actually handwrite it.
Yeah.
We think it's better to handwrite it. We think for I think a couple of very good reasons. I see that there's a question here, but let me just say this quickly that it's first of all, when people are typing, they either are very good at typing and they type at, 100 words a minute, or they're very bad at typing and they
Mhm.
end up, focusing more on the keys than they do about their trauma and their experiences. And so,
But writing, everybody sucks at, so.
writing everybody's like that, except the younger generation, they don't know from writing, right? They know how to text and all of that. So in any event, so we think that sort of being slow and thoughtful and methodical and not being focused on the keys of the keyboard is more helpful.
So it's almost like just a technicality, just to,
Yeah,
in terms of effectiveness of the work.
I think so, but there's also some neuroscience evidence to suggest that people learn better when they handwrite versus type.
Interesting.
Um, yeah, there are benefits to learning and memory when you write by hand versus typing on a keyboard.
Hmm.
And so, and I think that, there's obvious sort of connections there to kind of like healing your trauma if you're able to learn, if you're able to sort of like make different connections and insights to the experience. So,
Interesting.
but I do think it's an empirical question that we still need to be able to answer. We haven't
Okay.
done that work yet.
So just before we go to Yoel's question, I want to just ask you, does the clinician then explain to me the process of the clinician reading the process? Does the clinician read it in front of the patient when the patient's
No.
done later? How does that work? And then we're going to go to Yoel.
The therapist will read the narrative after the patient leaves. It is done after the fact, and then the therapist will give feedback to the patient the next time around. Again, as I mentioned before, the therapist will say, "You did a great job with this part of it. I really want you to focus on this part now and this next narrative." Or something along those lines, but never reading it in front of the patient.
Okay. All right, let's go to Yoel's question and then we'll come back for more. Go ahead, Yoel. Glad we got you in
Yeah,
this
yeah,
week.
yeah. And I was not at all upset. You do a great job, Maishi, and I appreciate it. And thank you to Dr. Marx for being here. I'll just a few quick questions, and then you can answer as you see fit. I have my primary exposure to written to my pro, to exposure to written exposure therapy or written processing therapy. What it was personal, dealing with my own trauma. And I didn't know that it was necessarily called that then, but I found it very helpful. A couple things that I remember and wanted to get your feedback on. One is that um, I was told by the therapist, if you don't want me to read it, won't read it. Um, I and then I wanted to just ask you, and now I've started to do it with clients, not formally because I don't have this training, but just recommending that they spend some time and often outside of therapy, and then if they want, they'll read it.
Hmm.
I wanted to know how does this work with complex PTSD? Moshe had a great guest not too long ago showing that there is a difference in certain modalities. When you do the psychoeducation, do you mention specifically that not only the avoidance, but that there's shame? I wanted to ask how much time it's important to spend building trust for this modality. And then really interesting. I when I was doing it, they had us write some of the time with our non-dominant hand. And you were
Mm.
just talking about the neuroscience, and this they told us just do it, and it was absolutely amazing. I I had been writing with my right hand, and I didn't feel a lot happening. I started writing with my left hand, and I started crying. And they say it stimulates, because it activates the other side of the brain. And it was absolutely incredible. And finally, this is a lot. Don't feel any pressure to answer everything,
No
but
worries.
comparing it to EMDR, brain spotting, and maybe Peter Levine's pendulation. How if you would have any comparison?
Sure. Well, thank you very much. That there's a lot there, and these are all really important topics and things we could spend, an hour on each of these, I would say. It's interesting. I'll talk first about your experience with having someone say to you, if you don't want me to read it, I won't. When we first started doing the expressive writing work, this is well before we developed WET, what we noticed, and let me just back up and tell you a little bit about the procedure that we had in those early studies, where this is with college students, but they had, this is on an urban campus in Philadelphia. Students had really horrific experiences of trauma. It was really quite shocking what these kids would write about: child abuse, gang rapes, being shot at, you name it. And we had them write in the little blue books that you use in classes, right? To write, when you're taking exams and whatnot, and we would give them their space to write. They would write in the blue books. We actually left the room. when we told them to start writing, when time was up, we came back in the room. They would take their blue books, they would stick them in an envelope, seal up the envelope, and put it in a little box on the floor. Okay. And they left and they would come back the next session for the next day for their next session of writing. What was really notable was that we never told anybody that we were going to read what they wrote. And yet they all assumed that we would, and they all wanted us to read it. It was like they wanted somebody to hear their story. And so when they came back the next day, they would talk to us as if we we read what they wrote. Even though we didn't tell them that we were reading it, they assumed it, they wanted it to be read. And I think that that was actually a very powerful thing to sort of like be seen, to understand that someone had understood their experience, that they were no longer burdened by this. These were things that people had never shared with anybody else in their lives, that they were sharing in intimate detail with us. It was really a very fascinating phenomenon that we observed. And so I think from my experience with, back then, but also, up till now, is that it's really important most of the time, if not all of the time, for people to know that you are going to read what they have put down. The only exception I can tell you is, when working with active duty service members or veterans, sometimes they engage in activities that they do not want anybody to know about because there are legal implications of that experience. And so, that is when, we kind of run into some difficulty because we have to be able to read what they've written in order to give feedback and so on and so forth. So, all of that is to say that sometimes wet may not be the right modality for a given individual if they're not willing to write, or if they even, let's say they even have a disability and can't write. That is, certainly a consideration as well. I want to make sure that I have time for other people, but let me also just take the question about complex trauma for a second. So we know that most of the time, people who have one traumatic experience have other ones. That is the norm. It's not typically the case that people just have a singular traumatic experience. Sometimes they have different kinds, car accidents, assaults, or what have you. Other times they have repeated incidents of the same kind of experiences, like child abuse, things of that nature. And it is often the case that for those folks, it can be challenging to select one experience to write about because there's a whole class of experiences that are very similar. The person thinks about different experiences that are of the same type with the same perpetrator and so on. And that's okay. But for the purposes of the writing, what we have found is that it's the selection of the event that the person is writing about is critical. And so it's fine that they have more than one, um, but they should, what we would like them to do, and this is what we ask them to do, is select a particular experience, even if it's one among several, that they think about the most, that bothers them the most, that is the source of their intrusions. It's the source of their nightmares. It's the thing that is, contributes to most of their suffering. We want them to write about that. The main point here is whatever they write about, it should sufficiently elicit a lot of affect. Okay. And that's the real key here. If they choose an experience that doesn't elicit a lot of emotion, isn't connected to a lot of thoughts and sensory experiences, it's not going to work as well. So, from that standpoint, it doesn't matter to me if they select, this one or that one or what have you, we want them to select one experience among many, but make sure that that experience is is salient for them, is distressing for them, and is really kind of connected to their symptoms and the problems that they're experiencing in their lives. And sometimes that's a challenge, but most of the time it's not. And just to also just make one other thing clear about complex trauma, if we're talking in the DSM parlance and we're talking about other kinds of co-occurring disorders like borderline personality disorder or things of that nature, what we have found, again, we haven't like done a systematic study, but just anecdotally, what we have found is for patients who have PTSD, but who also have, let's say, borderline features, this actually tends to work quite well. And the reason for that is that there can be, with patients that have personality disorder or borderline features, there can be, interpersonal tension. There can be interpersonal difficulties working with a patient like that. There can be trust issues. And all of that is obviated when you are just asking them to sit and write about their experiences. You don't have to kind of get into the interpersonal dynamics of things when you're actually asking people just to sit and write for 30 minutes. And we've found that, in those cases where we find the, people with comorbid borderline features, it actually works pretty darn well. And I will also just say one last thing, which is that if people have more than one traumatic experience, the WET protocol is brief enough that if you go through 5 sessions of writing and then you want to spend another 5 writing about another experience, you can absolutely do that. And so you're actually, in the time that, in let's say CPT or PE, you've spent working through one traumatic experience with WET, now you've worked through 2 in that same amount of time.
So is there a sort of assumption that by working through something from beginning to end, it will help to heal some of the other traumatic events?
Yes,
How
again,
does
if
that work? That must be a neuron thing.
well, if from a behavioral perspective, if you're constructing a fear hierarchy,
Mhm.
right? And so like you're making sure that you select an event that's at the top of the fear hierarchy, then it's presumed, and this is often the case, that the effects of, working with, a stimulus that's at the top of the fear hierarchy, those effects will generalize to events that are sort of lower down on that hierarchy.
Oh, okay. Um,
I see that Yosef has a
yeah,
question.
Yossi, if you want to ask, yeah, okay.
Yeah, I have two questions regarding complex trauma. Number one, do you find that when the writing exposure technique is used, that among with complex trauma that after dealing with one, you just go to the other and the other and the other, and it just continues on endlessly? And the second question regarding complex trauma is, well, sometimes with complex trauma, the memories are not intact, and also or the feelings are not associated with the memories.
Hmm.
How would you deal with that? And would it
So yeah, so we don't, I cannot recall any example of a patient who had, a complex trauma presentation in which we had to do repeated writings. We had to, start from the beginning. But this is why selection of the trauma from the get-go is very, very important. Sometimes it's the therapist and the client don't get it right. And you're 3 sessions in and you realize that maybe that you haven't selected the correct traumatic experience to process. And so we'll start over from the beginning. Um, but it's very important to do that work up front to select the right thing. If you are able to select correctly, you can do a lot of really good work, even with somebody who has years worth of trauma, and not need to process each of those experiences individually. I'm not going to say now, I mean, I don't want this to sound like this is too good to be true because if I were in your shoes, I would be like, I don't believe this. This doesn't make any sense. I'm very skeptical of this. I totally get that. As someone who's done this work for the last 25 years, I was skeptical at the beginning and I remain skeptical now. Every time we do a project, every time we do a study, I'm really just like it's not possible. And I've been continually surprised, but I feel like my skepticism in all of this is a strength, and I'm glad to be proven wrong. So all of that is to say that, like, you know, if you're thinking that all of this sounds too good to be true, I completely understand that. Um, I would just suggest, you know, that at the same time you keep your skepticism, but also, be willing to kind of like test these things out with your clients. And it's also the case too that, like anything else, not every treatment works the same for every individual, right? You have to have lots of things in your clinical toolbox, and you have to be able to kind of use different techniques with different patients because what works with one person is not going to work with somebody else. So maybe you have patients for whom wet is a good introduction and they make some good gains, but they need more. And you do other things with them following wet. Uh, you have other patients for whom you see a dramatic decrease in their symptoms with wet and they don't need to do other things. And sometimes you see patients who, they don't get any benefit out of it, just like anything else. It just really depends. What we need to do is we need to figure out, how to better match people with the treatments that we have available to them. What I can't remember now, what was the other question that you had about, was it about complex trauma? Sorry.
Yeah, what happens when a person is well, with complex trauma, often the memories are not intact. They don't have, because it's so much, like they
Oh,
don't
yeah, yeah,
remember it, or they disassociate also from the
yeah.
emotions.
That is a great question. Obviously, trauma-focused therapies, whether it be with wet or anything else for that matter, are really dependent upon people having a good memory for their trauma. Now, it is sometimes the case that we've worked with patients who dissociate, and we are in the room with those patients and we're there for them to do some grounding exercises if they start to dissociate while they're doing the writing. um, I think it's safe to say that, again, because they are writing, because they are grounded, by doing the writing exercise, the dissociation, I think, is less likely to occur, although we have seen it on rare occasions. But it is important for people to have good memories in order to do the writing. Sometimes people will say to us, I have a gap in my memory. This thing happened and then my memory is blank, and then I woke up and I all I remember is that I was in a hospital bed, or I was being pulled out of my car by first responders or something along those lines. And again, I would say, it's important to work with these people and to understand what may be the limits of their memory. We certainly don't want to create a situation where we're like creating memories for people. But that being said, um, I would say it's regularly the case that when you get people to start this writing, they start to remember things that they have forgotten. They start to kind of fill in the gaps. And again, you know, are they kind of conjuring up these details out of thin air, and that that they don't accurately reflect reality, or are they correct? It's not for me to say. I wasn't there. I don't know. The writing is not a lie detector test, right? I'm not there to judge the veracity of their writing. But if through the process of writing, they can create an organized story that makes sense for them, that helps them resolve their pain and their suffering, that's all that I'm there for, right? And so, I'm not there to plant memories for people, but through the process of writing, if they, and we see this, I would say on a fairly regular basis, that after the writing happens and we ask people, what was this like for you? How did this go? People will say, I remembered more about this than I thought I did, or I remember that person's name. We hear that a lot of the time from veterans and service members who they can't remember the name of the person that was with them and that died in that ambush. And they feel terrible about that. They feel ashamed. They should be able to remember this person's name that meant so much to them and that died right next to them. And for whatever reason, their name was blocked. And because they actually sat down and put pen to paper, all of a sudden it comes back to them.
Hmm.
And that is a really kind of a really fascinating thing that we have seen on a regular basis.
Brian, I have two more questions that I'd like to ask. I know the time is we're starting to cut it tight, so I want to try to get them out there. Question number one is, what distinguishes the writing that goes on in session one, session two from session four and session five?
Yes.
Is there um, are you guiding the patient or the client to write certain specific things, or are you just kind of like you alluded to earlier, tweaking what they may have missed and having them go back to it? Have they not finished the story yet after 30 minutes and they need to just continue writing? That's question number one. What are you doing from session one, session two? Are you changing the story? Are you rewriting the narrative? And then question number two is, which is kind of similar, is what are you looking to produce through the writing? Again, maybe
Hmm.
you'll see this as one and the same, but are you looking to produce something like, I just told you before the show that I'm training in ART therapy, and one of the things that we're looking to do is have the patient or the client rewrite the narrative to something more pleasant, to something happier. Do you have an agenda like that in WET, or is it just like write it out in as much detail as you can, get more detailed, and that will somehow help heal it?
Right. Yeah, I'm sorry that I didn't mention this earlier. I had meant to. But so the first three sessions are really focused on getting the details of the trauma out on paper. The third session is really an attempt to get the person to focus on the part or parts of the trauma that are the most upsetting for them, right? So the hot spot, the first two are like, let's kind of like get the details out. The third session is really focused on the hot spot, the piece of the memory that is most upsetting, most bothersome. Sessions four and five take a bit of a pivot and are focused on meaning making. Okay. So what we do in sessions four and five is to ask the person to talk about what this event has meant for you, how it has changed your life in both positive and negative ways, how it's changed your life, how it's changed your relationships, how it's changed your future, how you look back upon it now. And we see over time people's thoughts about and their insights about this experience change over the course of the writing. And so, we're not doing any active probing of people's cognitions. We're not asking about distorted thoughts and trying to correct them in any kind of Socratic thinking kind of a way.
Mhm. Mhm.
What we do see oftentimes when we get people to write about this and to really, first of all, focus on the memory and sort of like describe it all out and then reflect back upon it and talk about what it's meant for them, um, and their lives, their trajectories, how it's, caused problems for them, how they've overcome those problems, what the future may look like for them. There's a perspective taking that I think can be very, very helpful to people that oftentimes they don't think to do, and don't have an opportunity to do. And I think that that perspective taking can be really powerful for people when they realize, for example, that they have overcome adversity in their lives, or that they can see patterns in their relationships that they weren't able to see before. But now, because they have put this thing down on paper, and then they walked away, uh, they let a week go by and they come back the next week into session, and they've actually spent a lot of time thinking about their trauma. And perhaps even more importantly, they have spent time now sharing details with others in their lives. That is one thing that I want to make very clear here. And Pennebaker noticed this in his original work, that people would write about these stressful or traumatic experiences, but what they also, and that, expressing emotion was cathartic and helpful. But what he also noticed was that people, once they did that, once they unburdened themselves through writing, they felt like they now had permission to tell other people about these things that they had never told of
Mm,
these other people before.
mm.
And that's what happens here in written exposure therapy as well. They go back into their lives, they tell their families, their spouses, their friends, and it's that kind of social connectedness now that has other benefits, that helps them sort of help and heal. And also perhaps they come into the next session and they have sort of a bigger perspective about what happened to them. And they have this sort of positively reinforcing experience where they've shared with other people. And so there's this feedback loop that happens in all of that that can be really powerful for people.
And this is really adequate. I mean, to make meaning is really adequate in 1 or 2 sessions, in session 4 or 5 or just 5, to make meaning and in just 30 minutes.
Well, a lot of the time, yes. Not all of the time. We originally it was only 5 sessions. We've now permitted, I guess, depending, upon what happens in early sessions and what the clinician's judgment may be. It's, in my view, in our view, Denise and my view, reasonable if let's say, a therapist wanted to add another session or two, because for whatever reason, they didn't do a good job disclosing the details in session one or session two. Adding an additional session to do more of the exposure work or to do more of the meaning making, if the clinician thinks that it's warranted, is fine. But I will say that we just had a paper published that suggests that most of the time you don't need more than 5 sessions. Clinicians tend to err on the side of, thinking that more is better, although it may not necessarily be the case.
Okay, let's take one last question from Shauna.
Hi, thanks. Okay, so two quick questions. One kind of on what you were just discussing, kind of on the flip side, would it ever be beneficial to kind of implement like 1 or 2 sessions of this in a more informal way as part of, a different general modality? Um, and separately, I was wondering, so kind of the way that I see the writing is that it gets rid of one of the barriers of shame in general,
Hmm.
by having, the ability to write it instead of verbally speak it.
Absolutely.
But I'm curious if it addresses, the common guilt that people have when they've experienced trauma, and if they, in some way, take less responsibility or are able to shift the responsibility off of themselves through this.
It can. I don't think it's necessarily possible to do in one session. But yes, we have seen that. There's a really good example that we use frequently in our training of a woman, one of our patients who was assaulted and blamed herself for the assault. And, very, I would say, lightly during the one of the check-ins, sort of like asking this person after the writing to kind of ask them, because she was stuck on, being responsible for what happened to her. Um, but through the writing, after one of the sessions, she was asked to, if responsibility was a pie, what percent would you ascribe to yourself of responsibility? And she gave an answer initially of of 15%, and then corrected herself and said, "No, wait a minute, it's zero." And I think it was, really just, like I said, we didn't do anything to really challenge those beliefs, but it was a function of her sort of being able to take perspective through the writing about what happened to her and seeing like, actually, it wasn't me. It wasn't my fault. I didn't do this. I didn't do anything to deserve this. This person just assaulted me. But when just simply asking them now to, how much responsibility do you bear for this? They realized that they were not responsible at all. But I don't think that it's like that's likely to come just from one or two sessions. I think you probably have to do more than that in order to get the person to that conclusion.
And is this helpful to do on one's own without a therapist in the room, just to write out the traumas? Is there any risks to that? Is it
Uh,
helpful therapeutically?
it's an excellent question. Um, I wouldn't advise it. I don't think that there's anything necessarily dangerous about it, but I worry that people don't follow the instructions and then, then they say, didn't work for me, right? And they don't have someone there to kind of give them corrective feedback. And they say like, well, this was unhelpful, but they never really did it the correct way in the first place.
Hmm.
And so that would be my primary concern.
Okay, I want to thank Dr. Brian Marks for joining us tonight and sharing his expertise and knowledge and insights on wet therapy or written exposure therapy. Thank you very much for agreeing to come on, sharing this with us, giving some food for thought. Are there any trainings that we should know about, any resources that we should know about? We already shared your book, Written Exposure
Yeah.
Therapy. What else can we know?
Thanks very much for asking. So we just did a training for PESI. I don't know if you are familiar with PESI, PESI. We did it back in January, and you should be able to get the training through the PESI website if you're there. You go. Yep.
Okay, excellent. Well, thank you very much. Thanks again, and have a good night. And keep doing good work and keep up this important mission.
Thank you so much for having me. It's a pleasure to be here with you all. Thank you.
Okay, good night. Bye bye.
Bye, everyone.